Welcome to EconTalk, part of the Library of Economics and Liberty. I'm your host, Russ Roberts of George Mason University and Stanford University's Hoover Institution. Our website is econtalk.org, where you can subscribe, find other episodes, comment on this podcast, and find links and other information related to today's conversation. Our email address is mail@econtalk.org. We'd love to hear from you. My guest today is Arnold Kling, who blogs at EconLog, part of the Library of Economics and Liberty. Arnold has written on a wide variety of economic topics and is the author of Learning Economics. And his most recent book is A Crisis of Abundance, Rethinking How We Pay for Healthcare. And that's our topic for today. Arnold, welcome to EconTalk.
Thanks. I enjoyed listening to your broadcasts.
Arnold, what do you mean by a crisis of abundance? Sounds like an oxymoron.
Well, it's meant to sound like an oxymoron. I note that we could actually pay for the health care that we had in the 1970s, which was pretty decent health care, and we could pay for it pretty easily. But what we have now is an abundance of specialists and high-tech medical equipment, and paying for that has become more difficult.
So you see the increase in healthcare expenditure, which a lot of people bemoan, as the result of improvements in both the type of people who administer healthcare and the tools that they have to use.
Well, I'd have to be careful about attributing it to improvements because it's not clear that we've gotten enough bang for the buck in terms of healthcare. And I would say, in fact, that when I began writing the book, there's this puzzle that the U.S. spends so much more on healthcare than other countries, and the other countries have longevity that's as good or better. And when I started writing the book, I was actually looking for evidence that to resolve that puzzle in our favor. And I didn't find much evidence of that sort, so I'd be a little cautious on that.
But we do have, quote, better diagnostic tools. We have a wider array of pharmaceutical interventions that are possible compared to 1970.
Yeah, there certainly are better things available than what we had in the 1970s, and there's definitely been an improvement. The question is whether the improvement matches up, is at all proportional to the increase in spending. But the important point is that it's not some evil gremlin that's stolen the money. The money is going for real stuff. It's going for real procedures. It's just these procedures are very expensive. They involve the use of specialists. They involve the use of high-tech medical equipment. And that's really what's driving the spending.
We wouldn't normally take that perspective in other areas. So if we looked at, say, cars, and we compared an automobile today compared to an automobile in 1970, we'd say, well, one perspective would be, well, there's a lot of improvements. There's more cup holders. The cars are a little less likely to break down. They get better mileage. They're safer in the sense that they have more stuff, airbags, more types of crumple zone stuff. And you could counter and say, yeah, well, the cars look like they're improved and they're fancier, but whether those are really worth the money, we can't really say. But most of us as economists would say, well, the producers put those improvements onto the marketplace. Consumers preferred them to the alternatives, and so we're comfortable saying those are improvements. We might not be able to quantify what 8 cup holders are worth, or having a GPS system or a CD player with holding multiple CDs. But we say, well, consumers paid for them, and therefore we presume they're worth it. We don't have that presumption in healthcare. Why not?
Well, you use the word consumers paid for them, and in healthcare, consumers pay for less than 15% of spending out of pocket.
Who pays for the rest?
The 85% of it is paid for by third parties. So it's mostly health insurance. Government provides about half the health insurance, and then private insurance provides the other half.
And that private insurance is subsidized by government through tax deductibility, usually.
Yes, in part.
And therefore?
Well, if you're not paying for it, you're not as conscious about it. But going back to your question, you really can't assert that it's consumer choice that's driving this increased use of these procedures. Presumably, some of it would be consumer choice, but if people had to confront that cost more directly, my presumption is that they would not choose as many of these high-tech procedures. Now, I just want to pause because one issue is that that's very counterintuitive to people because people tend to think of healthcare in black and white terms. You either need it or you don't. And if you don't need it, you don't get it. And if you do need it, well, cost it shouldn't really be an issue. But there's a lot of these medical procedures are truly in a gray area. They're neither absolutely necessary nor absolutely unnecessary. And I'd like to give a few examples.
Yeah, please.
One is you just turned 50 and your birthday present is you should go for a colonoscopy.
It's bad enough you turn 50, but you get a colonoscopy as your big present for the big 5-0. It's lovely.
Lovely, yeah. But Oprah tells you to do it. Everyone tells you to do it. I'm sure your wife tells you to do it. And, it's to screen for colon cancer. It's not absolutely necessary. It's not absolutely unnecessary. It's somewhere in between. You aren't guaranteed by any means to die if you don't get it, but it does improve your chances of not ending up dying of colon cancer.
But it's expensive, and there's a risk of complications during the procedure itself. So it's not a freebie, even if you don't pay out of pocket for it.
Right. There's non-monetary costs as well, but there are also monetary costs. And another example, again, no risk factors, no symptoms, but you're about 40, and a routine checkup, they find microscopic blood in your urine, and the doctor recommends more tests. Well, it turns out that there are probably 10 to 15% of the population that's walking around with microscopic blood in the urine. They don't know it, and they're none the worse for it. So again, these additional tests are neither absolutely necessary nor absolutely unnecessary. Third example, you hurt your back moving furniture. Should you go for an MRI exam? Again, neither absolutely necessary nor absolutely unnecessary. And then I'll give one more example, which is based a bit on Michael Moore's movie Sicko, where he shows a woman who's very distraught. Her husband had kidney cancer, and the doctor had proposed a radical treatment that included bone marrow transplants. But this was turned down by the insurance company, and Michael Moore and the woman want you to believe that the insurance company turned it down, A, because he was black, and B, because they wanted to save money. And as a result,
they only care about profits. They're heartless. That's what happens in a market-driven system.
Yeah, they killed the husband. Well, if you if you look into cancer treatments that are aggressive and that involve bone marrow transplants, they actually have a very dubious history. Shannon Brownlee has a new book called Overtreated, and one chapter is on the history of bone marrow transplants and radical chemotherapy for breast cancer. And originally, all the breast cancer lobby was very much for it. But after about 10 or 15 years, they found that it was doing more harm than good, that it was killing some people. Most people it wasn't saving their lives, and the people that it wasn't saving, it was creating a very undignified and painful death. And so they've backed away from that. So again, if somebody said, okay, I'm aware of all these things, and I might have an undignified and painful death, and this isn't going to work in most cases, but I still want to do it. So you can't say to that person it's absolutely unnecessary. But I certainly wouldn't argue, and I don't think anyone would argue that it's an absolutely necessary treatment. So you have these things that are neither absolutely necessary nor absolutely unnecessary, and they're what makes healthcare a difficult issue. You can't just say, well, let's settle it. Let's give everyone a right to healthcare. Let's not even talk about a choice of healthcare. Let's give everyone a right to healthcare. Countries that say that they give everyone a right to healthcare probably would not do any of those four procedures that I gave as my examples. They wouldn't do the routine colonoscopy. They wouldn't do the additional screening for microscopic blood in the urine. They wouldn't do an MRI for a back injury, and they certainly would not do cancer therapy, desperate cancer therapy involving bone marrow transplants.
And they don't, you're saying, actually, in countries that have quote, free health care.
Or universal or a right to health care. You can't get past the difficult decisions in this gray area where procedures are neither absolutely necessary nor absolutely unnecessary. That's where it turns out there is some real economics of healthcare that economists, as you've had Robert Frank on this program, and he's talked about economists looking at things in terms of costs and benefits. And people don't like to look at costs and benefits when it comes to healthcare, but when you have these procedures that are neither absolutely or necessary nor absolutely unnecessary, somebody has to make those cost-benefit types of calculations.
On a market system, which we do not have, it's important to say. I always like when people say the market for healthcare doesn't work. Just look around. We don't have a market for healthcare in the classic free market sense. There are market forces at certain parts of healthcare, even in the current highly subsidized system and highly regulated system. But in a market system, in the case of cars that we talked about earlier, the cost-benefit trade-offs are made by the consumers, imperfectly, of course. Sometimes you buy something that it turns out you didn't value as much as you thought you would, or it ends up costing you more than you thought. But the consumer makes that choice, and innovation takes place in that market system based on the expectations of the innovators about what the benefits and costs of improvements might be. In a non-market system, which is what much of the world has embraced in healthcare, and even the United States has embraced to a great deal, those decisions about cost and benefits get made politically, and it's a different set of trade-offs than would be made by a market system.
Yeah, that's true, and I think it's important to emphasize your point that we do not have a market system in the United States. There are two issues, one of which I deliberately didn't deal with in the book, and we can certainly pass over on here, which is on the supply side, that what a healthcare provider can do is tightly regulated, and that limits the ability to, on the supply side, to rationalize the healthcare system, to make it as efficient as possible. But on the demand side, we have these layers of insulation from cost. That is, as an individual, you typically do not pay for your own health care. In fact, if you walk into a hospital with cash or a credit card, they'll look at you like you've just urinated on the sidewalk. You're supposed to show this magic insurance card that is going to be photocopied, and that doesn't involve you paying at all. And it's even more insulated than that, in that the insurance card itself, you often don't know what it costs to provide it because it was provided by government, or it comes through the employer, and people don't get have a sense of what the employer is writing the check for. I hesitate to say the employer paying for it, because I think a basic economic principle is that workers are actually paying for their own health care. It's just
in the form of lower wages.
In the form of lower wages. But so anyway, so you're right. We don't really have a market system, but and we don't have a market system anywhere in the world. And one of the things that you have to ask about that is, why is that? And as I was writing the book, I began to lean more and more away. I combined two things. I talked about the institutions that we have and how they produce the incentives that they do. In particular, they don't produce an incentive to make very careful cost-benefit decisions. And so I say that our system has incentives that enable us to make extravagant use of medical procedures with high costs and low benefits. And I talk about changing the institutions to change that. But at the same time, these institutions have to reflect, in some sense, our values and beliefs and illusions about healthcare. And I think they're worldwide, people really love free healthcare, or what they think of as free healthcare. It's hard to get away from that.
Yeah, no, there's no doubt about that. That there's some force there, that desire for not having to worry about that cost-benefit trade-off that seems ubiquitous. I want to come back to your hospital example where you show up with cash or a credit card. Not only is that considered bizarre by the system, but even more bizarre would be to behave like a consumer once you've passed through the payment portal into the treatment portal, treatment area, which would be asking what something costs. So if you ever have a child and you go to have your child in a hospital, in the lead up to that experience and the experience itself, there's an enormous number of tests, procedures, treatments that are presumed to be mandatory, even though, of course, they're not mandatory. They impose these. Many of these have no monetary cost to the delivering mother, but they have health risks. They have psychological costs. They create anxiety. And if you say to the doctor, well, I'm not sure we want that, and that could be anything from some sort of prenatal screening test to an epidural during the delivery, they look at you sometimes like you're crazy. And if you then follow it up by saying, well, what's it cost? Not only are they unprepared for the question and find it surprising that you might ask, they don't know the answer. And the answer any answer they might give is really not a real answer because they don't sell it. They don't. Your bill doesn't go down if you forego that. Your bill doesn't. So there's all kinds of overhead imposed on those numbers. I remember, getting a glass of my wife asking for a glass of orange juice. The official cost of that glass of orange juice, I think, was something in the dozens of dollars. Like a $40 glass of orange juice. I don't know if that's really what it cost. I don't know what that number really meant. But I remember thinking, if I were paying for that, we probably would have brought our own orange juice. It's a little bit of a hassle on the way to the hospital or the day before to be prepared for that. But people would take those kind of precautions, and those are areas where the grayness is really dramatic.
Yeah, there are a lot of decisions that consumers would make differently. A woman named Maggie Mahar, who is not an ideological soulmate of mine by any means, but has a very interesting blog called Healthbeat. Just the other day had a post where she suggested that doctors and patients should really have conversations about procedures, and if they did have conversations in which the doctor admitted that there was some uncertainty and this thing might not work, that individuals would often choose not to have procedures. And so she made it sound like, well, if we just had better conversations between doctors and patients, everything would be nice. And my response to that is to think, well, why doesn't that happen? And I can go back to my own history, and I talked about the 40-year-old man who's finds microscopic blood in the urine. Well, that's an example from my life. And I had a Harvard-trained doctor at the time, and I computed some probabilities using Bayes' theorem. It said that this symptom is kind of meaningless because the incidence of serious illness at my age and with being a non-smoker is very low. The incidence of the symptom is high, and if you do a Bayes' theorem calculation, there's nothing to get excited about. Well, A, he didn't understand Bayes' theorem. B, he got very angry and worse than defensive. I mean, not only
I'm sure he was offended.
Oh, deeply. And so, the idea that deeply offended. Yelled at my wife on the phone about this whole thing, and so kind of the opposite of the conversation that Maggie Mahar is recommending for people, and I think that's more typical. And again, I want to go back and say, well, what is it about our illusion? Why is that important? And I think we have an important illusion about the doctor knowing best. So I think there's a reason why we want the communication to be one way from the doctor to the patient, is that we don't want to hear about the uncertainty involved. Most people would rather have the illusion that the doctor is God, and a lot of doctors prefer to live. I mean, clearly my Harvard-trained doctor would much rather be treated as God than to have a patient question him. And that's an element of our system.
Well, I'm sympathetic to that viewpoint, although I wonder how much of it is the result of the current set of cost structures. I think in a world where consumers paid for the cost, they'd be more likely to have that conversation. The doctor would be more likely to be tolerant of it. And my guess is that in areas where consumers pay the cost out of pocket, such as LASIK surgery, those kind of conversations take place without rancor, without offense. But it's a very, very interesting question. I mean, one way, again, to think about it is I don't know much about cars. I like the idea of having a mechanic who I can trust, who when that person says, fix this, I say, oh, it must be necessary. Now, but I know that's not true. I don't have any illusions about that. And my goal in life in the mechanic area is to find a mechanic who I think would feel guilty and have pain making me do something that was unnecessary, and his competition forces him to do that with less frequency. So it's interesting that in that setting, I really don't have any illusions about my mechanic. Now, we understand that healthcare has this emotional part to it that Robin Hanson talked about in an earlier podcast. It's closely related to death, and we have all kinds of strange ideas about death that probably affect our thinking. But it's a very interesting question. Let's go back to the narrative we started. You made the observation that in today's world in the United States, only about 15 cents of every dollar of healthcare is paid for directly by the consumer out of pocket. That's a big change over time. If we go back to 1960, say roughly 50 years ago, that number was dramatically higher. If I remember looking at the data, do you remember that offhand? It's at least 50 cents. I can't remember.
Yeah, it certainly has to be above that because that's before Medicare.
Yeah, so before Medicare, which was 1965, the average American was paying more than 50 cents on the dollar for for a dollar of health care, and that number has fallen pretty steadily when I've looked at the numbers a while back to 15 cents, from 50 to 50 or over to 15. That change is a big driver of our expenditure on healthcare.
Indeed, and in crisis of abundance, the main policy proposal I make, or institutional proposal I make, is actually to push that back up to a number of around closer to 50%. My diagnosis of the system is that we make extravagant use of procedures with high costs and low benefits, and I argue to change that, we need to give consumers the means, the motive, and the opportunity to make different decisions. And for the means, I think they need more information about the costs and benefits of healthcare procedures. And I don't think anyone has that right now. I don't think the doctors have it. Again, I don't think my Harvard-trained doctor really understood the probabilities and the costs and benefits. And you had Ian Ayres on this previously. In his book, he has doctors look at. He has an example of a Bayes theorem problem for doctors where they're supposed to calculate probability, and 3/4 of them get it badly wrong. And that's kind of a bad sign. So I don't think the doctors know the costs and benefits because they're, in part because they don't know how to make these calculations. The patients don't know it. And so, one concern about just sort of handing the consumer the responsibility without the means is that consumers will just cut back uniformly on all forms of healthcare, not just what's cost ineffective, but just even the good stuff. And so I say that we need to give them the means. And one of my more non-decentralized proposals is to have a commission actually study costs and benefits of healthcare procedures. To give people the means, but then they also...
Such a commission might emerge without a centralized
mandate. If there were the motive, if there were the motive, consumers might ask for it, just as consumers, just as somebody who's buying a car all of a sudden gets interested in Consumer Reports, somebody who's interested in healthcare might be interested in statistics on what procedures are appropriate. Certainly consumers do a lot of research on the internet that suggests that they have some interest. But we need the means, and they need the opportunity. That means that having a doctor who will have an open conversation rather than saying "me doctor, you patient, you do what I say," and the motive. That is, you have to have consumers paying higher co-payments and higher deductibles in their insurance, so that they have more of a motive to care about costs and benefits.
You've mentioned Bayes' theorem a couple of times. Can you give our listeners an idea? We'll provide a link to something a little more easy to read. It's not easy to describe Bayes' theorem without a blackboard, perhaps, but I'm going to give you a chance. When you say you use Bayes' theorem to evaluate your own the likelihood of getting help from a treatment for microscopic blood in the urine, and the doctors don't understand Bayes' theorem. What do you mean by that?
Okay, well, let me give an example. This is Megan McArdle, who's another economics blogger, gives this story. Suppose you have a blood screening for a rare disease. I think this was lupus, and let's say that you get 1 out of 1,000 people actually have the disease.
So it's very rare.
Very rare. And there are 4 outcomes when you do a test. You can have a true negative, meaning it tells you don't have it, and you truly don't have it. You can have a true positive, which tells you have it, and you really have it. And you can have a false positive, where it tells you have it, but you don't, and a false negative, where it tells you don't have it, and you do. Let's say that there's a 0% false negative rate and a 5% false positive rate.
So hang on. So 0% false negative. So the test...
If it says you're okay,
then you really are okay.
You're absolutely fine. Now let's be careful about what the 5% false positive rate means. The typical doctor, and many other people, think that if a 5% false positive rate means that if you test positive, that must mean you have a 95% chance of having the disease.
Right. 5% false positive seems like a low number.
Yeah.
So it means overwhelmingly most of the time, if it says you have the disease, you actually do.
Okay, but now let's do the calculation taking a representative sample of 1,000 people. Since we said 1 out of 1,000 people have the disease, there's going to be exactly 1 true positive out of those 1,000. If there's a 5% false positive rate, there are going to be 50 false positives.
Out of the 1,000.
Out of 1,000.
That's 5% of 1,000.
Yeah. So we have 1 true positive, 50 false positives. So if you test positive, you're 1 out of 51 people. You have a 1 out of 51 chance of having the disease, or less than 2%.
Which is not 95%.
Which is not 95. And most doctors just don't understand that. And Megan was figuring her doctor didn't understand that, because if you really understood that, you wouldn't even give this person the test, because it's not actionable intelligence to come back with a positive.
And again, let's make it clear why that's the case. It's not because, tests are wasteful. It's because this disease is so rare, and the test is, even though it's pretty good, it's imperfect. And that's the key point, that no test is 100% perfect. And we've eliminated one aspect. We've by assumption, created one little element of perfection here, which is that if the test says you don't have it, you really don't. Mm-hmm. But in life, tests...
They can err in both directions. Yeah.
And those errors can be, the test is imperfect, it could be a laboratory error, it could be all kinds of things that could go wrong. But just even if there's no lab error, tests don't perfectly measure the danger involved of the likelihood of you having this disease. It's not 100% if the test comes back positive. And in this case, 5% error rate, which seems like, it's a pretty reliable test, is actually, because of the rarity of the actual underlying disease, is, as you say, probably better not to get tested for it.
It's a complete waste.
And we ought to spend our time trying to make the test more accurate.
Or not bother, because in this particular case, it's a disease that there's no known treatment of until somebody shows symptoms. So to even do the screening...
I think here's one interesting way to look at this problem. You're arguing that if consumers paid closer to the full price for the healthcare they consume, they'd make wiser decisions. But at the same time, we know that politically, that's going to be a very difficult argument to make, either because people don't appreciate the underlying economics, which is, this free healthcare isn't free, and you're really paying for it in the form of higher, lower wages or higher taxes. But it's also possible that people just like not having to make choices in this area, this emotional, psychological problem we have, and they don't want to pay 50% because they'd rather just not have to think about it. Either of those is very depressing for any hope of political reform.
I'm a pessimist on political reform. And in fact, I don't think any meaningful reforms are being proposed. People want to sort of shuffle around the financing. So let's throw a few more people onto the government or do something like that. But I haven't seen anyone suggest anything that would produce a large change. The two large changes you could see, if you were to make what I call a left turn in healthcare policy, it would be for government to really crack down on the procedures that get done and start telling, either by limiting the supply or by specifically ruling
mandates,
specifically ruling out certain procedures to just sort of cut down on the procedures that get done. And what I call the right turn would be to give consumers more responsibility. But it's very hard to do that.
Talk about the iron trilemma, which I think is a nice an image you use to highlight these political challenges. These are inevitable trade-offs that people like to ignore in politics and sometimes in their personal life, but are not going to go away.
Well, yeah, let's say we want three things. One is as we've been talking about, we really seem to like being insulated from the costs of healthcare. Everybody seems to like to not have to think about money when it comes to healthcare, and there could be any number of reasons for that. We've listed a couple. And secondly, we like unlimited access to healthcare procedures. This is America. We're not going to, if somebody says, Russ, you've got a tumor, we'd like to do something about it. How about next March? You'd be, next March? Are you nuts? I mean, I want it out by Thanksgiving. Don't leave that tumor in there till March. So we have this, we want unlimited access
to the best care now.
Yeah, best care right now. And then at the end of the day, we also have to worry about what it all costs. And you can't have all three of those things. You can't have unlimited access, individual insulation from the cost, and then the overall healthcare costs not come back to bite you.
Well, let's talk about the single payer option, which is, I think, a seductive option for some people. Politically, is it never seems to die, and the idea here would be that government would run the healthcare system, and it would be more streamlined than the current system. The current system has this horrible mishmash, this crazy quilt of different payments and insurance companies, and doctors spend all this time on paperwork. But if we just had a government system, we'd be able to take all these costs out of the system.
Well, there are two issues there. Is sort of, would it be a sort of a more humane system, and then would it be a less expensive system? Whether it would be a more humane system is something you can argue about in terms of your preferences and so on. Would it be?
Because some people who maybe can't afford health care under the current system would at least have some access, so there'd be some benefits. Right?
Yeah, but as to whether it would be a less expensive system, I think you have to look at evidence there, and the evidence strikes me as no, unless what you're talking about is government cracking down on procedures. But if you assume that there's no change in the way in our access to health care, that we continue to have as much supply and as ready access to health care, then you clearly are not going to cut back expenses, because just arithmetically, all of the villains and scapegoats, of drug company profits or insurance company overhead, arithmetically they're not large, and they're not what accounts for the big surge in healthcare spending, if I can use that term, in the 1970s. The surge has come from actual medical procedures, and these are mostly the procedures that involve specialists and high-tech equipment. That's where the spending is, and so if you're going to cut costs, what that has to mean is that you have to cut back on the use of those procedures, which means that if we're going to have a single-payer system that actually is able to function in this country, that means that government is going to, at some point, really crack down on procedures. Even Medicare is going to face that. I mean, my description of Medicare is it's the fiscal equivalent of the Titanic. There's tens of trillions of dollars of unfunded liabilities in Medicare, meaning that the difference between what we've promised future recipients in terms of benefits and the taxes that we're going to collect, there's this huge shortfall. And that's the iceberg that the Medicare is headed toward. And when people talk about single payer, the first thing that occurs to me is that they're talking about adding passengers to the Titanic. And we got to figure out...
Or making the iceberg bigger, one or the other, yeah. Making it less likely we could avoid the iceberg.
And, and ultimately the only way what we're going to do about the ice. So people on the left, when confronted with the Medicare deficit, will say, but that's all just costs. All we have to do to get rid of the Medicare deficit is get rid of costs, and as if there's this separate entity called costs that has nothing to do with medical procedures or healthcare, but the costs are the procedures.
And I think the seductive part of that you've mentioned, which is that it's appealing to think that the source of those costs is the greedy profiteering of pharmaceutical companies, insurance companies, and there's just not enough
That's like
money there.
Rounding error in the overall medical budget. Yeah.
Let's talk about the innovation for a minute. This is an area I've not read anything on. I've not heard it discussed, and I suspect part of the reason for that is either because I don't read widely enough or because it doesn't lend itself as well to modeling or empirical work. But here's the question. In the legal environment today, something we haven't talked about, there's a lot of defensive medicine practice just because of that legal environment. Tests get run for fear of malpractice suits, regardless of their efficacy. So that's one of the reasons that we get both high expenditure and expenditure that doesn't pay for its benefits. It's not worth doing, but because of the legal risk, it's recommended by doctors. So we understand that. Here's the puzzle I'm thinking of. If you're an innovator in the medical world, you're a biotech or a medical device company, if you come up with a better way to image, you come up with the CAT scan, you come up with the MRI, you come up with a better diagnostic tool, a better screening test, what is different in today's legal and payment environment compared to that 1960s world where consumers had to pay for it? And I'm asking that because I think one of the benefits of the current system, it's not a benefit that covers its costs perhaps, but one of the benefits of the current system, it seems to me, is that we are an incredible innovation machine in medicine, in the pharmaceutical area, in medical device area, and we pay for it. We give it to the customer without having the customer pay the cost. I'm wondering about the incentives to come up with those innovations compared to a system that is more market-based. In other words, once the device is out there, it's very difficult for a doctor to not use it, not use best practices. What lets that device get out there to start with? There is, I think, a market mechanism there that's interacting with that subsidy and giving us devices that sometimes are glorious, but sometimes are not worth what they cost.
Well, I've talked in kind of negative ways about the healthcare system. And one thing is that there is this incentive to innovate. I should mention there's a paper by Amy Finkelstein on the introduction of Medicare, and it shows definitely that Medicare helped induce more demand for innovative services. I think that's her paper. I'll have to
Well,
make sure
Jack, we'll put a link up.
It's a good paper. It's a good paper anyway,
or the other paper, whatever it is.
So there's been a lot of induced innovation as a result of this sort of all the demand subsidies that we have. And I do want to put in one good word for our healthcare system. Like right after Michael Moore's movie came out, I wrote a paper about sort of my wife's documentary of our healthcare system, which consisted of...
And Michael Moore's is an indictment of America's healthcare system as cruel, profit-driven, people dying because of lack of treatment, et cetera.
Right. And my wife's documentary consisted of photos from my daughter's college graduation, at which three of the stars, including my daughter, my wife, and my father, all were saved by America's healthcare system. Well, my daughter wasn't literally saved, but she has a chronic illness that was much under control. She would never have gotten through college without her medical treatments. And in the case of my wife, which is, she's a breast cancer survivor. In case of my father, he's a heart bypass survivor. These are all treatments, and he's taking medications that. All three of them have taken medications that were not available, 15, 20 years ago. So they've clearly benefited from this innovation.
And these medications actually have improved their health,
even
though we've
question.
talked a lot about tests and treatments that are uncertain or dubious value, we don't want to suggest that there aren't glorious medicines that keep people alive.
Yeah, no, and a lot of these innovations do help. And my book starts out with an instance of an MRI for somebody with back pain, of all things, saving this person's life. So, it's not as if all of these things are bad things. So the innovation is an important thing. And one point that I would make is that the healthcare systems elsewhere in the world don't promote it. You talked about this person who built the better mousetrap, the better imaging thing, the one thing that they're going to do with it is they're going to introduce it in the United States, because this is the one market where that's really receptive to innovation.
And you can make a lot of money selling it. In a lot of other places, you develop that new wonder drug, and the government's going to, since they're the only dispenser of it, they're going to set a price for it that is not anything like a market price, and they may decide that at the cost of your development costs, they're not going to cover those costs. It's not worth it, which is what happens around the world. Whereas here, we gleefully give everybody everything, which has this unpleasant, unfortunate cost side, but it does create that incentive for innovation. It's an important thing to remember. Let's turn back to the political world, and I want to ask you an unreal question, and then a real question. The unreal question is, you've already said you would move us toward a more responsible healthcare system, in the sense that consumers would be more responsible for their payments. What's your ideal system? I mean, I can imagine a political world where consumers had to pay more of the costs, and that was politically preferable to a world where consumers had to give up certain treatments. So I can imagine that world, but is that your ideal? What would your ideal world of healthcare be?
That's a good question. I actually think that I favor, and I noticed that actually John McCain came out with something, I believe it was, McCain favored this, having more experiments at state level, because I don't think we know what the ideal system is. I wouldn't mind seeing a few states experiment with single payer, just to see what it's actually like. Because who knows, maybe there really are these efficiencies, or maybe smart bureaucrats really can make better decisions than decentralized people. So it'd be worth trying.
They'd have to be smart Arizona bureaucrats, though, relative to the unsmart Canadian bureaucrats, because we have a lot of evidence of how single payer works, both its attractions and unattractions. So it's hard to really argue that if Arizona went to a single payer route, that somehow it's the problem with the Canadians. The problems with the Canadian system would disappear because it would be run by Arizonians, not Canadians.
Well, you never know. Maybe maybe with competing with other states. Who knows?
Could be.
I certainly would like to see some states try more market-oriented systems. I think the ideal would be on the institutional side for paying for healthcare would be pretty close to what I have in my book, where I sort of have this, an institutional setup where government pays for the poor, where there's most people have sort of long-term catastrophic insurance, and some people who maybe have been ill for so long that their long-term catastrophic insurance has run out, they also have kind of a government backstop. On the supply side, I also think we ought to have a less rigid system. We say that if you're going to get an antibiotic for strep throat for your kid, that has to come with a doctor's prescription. A guy, somebody with an MD. If you're going to get physical therapy in Maryland, pretty soon you're going to have to get it from someone with a doctorate. They just keep raising the requirements, and I can't believe that there isn't at least some physical therapy that could be done with someone with like the equivalent of an auto technician school thing, not even an undergraduate. So these rigid licensing requirements, I think, have to go if you really want to have the ideal system. And then I could imagine, there are some people like Shannon Brownlee. I mentioned her book before. She really thinks that HMOs are really the way to go, and she chided me for confusing HMOs and managed care, saying, but an HMO would be a centralized system with lots of different healthcare providers that they bring to bear on the individual as needed. And I think to make that system truly efficient, you have to get rid of the licensing requirements so that HMO could train its people in whatever manner it chose to do what it chose. And then I could imagine dramatic cost reductions in healthcare.
You mentioned health insurance in passing. I think we ought to say something about that. I want to make sure people understand when you talk about catastrophic health insurance. We currently don't have anything like catastrophic health insurance for most Americans. We have a much broader coverage beyond catastrophe.
Yeah, I call it insulation, not insurance.
Right. And explain that. You say insulation, not insurance.
Okay, the purpose of insurance is to protect people from financial risk. That means a large but rare loss. So if you think of insurance like for your homeowner's insurance, the premiums are low. You make claims very rarely. So a lot of people have never made a claim on their homeowner's insurance. And the claims, when they're made, are for really big amounts. A big fire, major theft.
A tree goes through your house and causes $50,000, $100,000 worth of damage.
Yeah. So that's insurance. Low premiums, rare claims, really significant financial claims. Health insurance is the opposite. High premiums. Of course, you often don't see the premium, but when your employer is paying $12,000, let's say, for a family of four, that's often that high. And so the premiums are high. You make claims all the time. Every time you get any kind of health care, you fill out the form.
It's not for unexpected events. It's often for things you're planning,
and
like a pregnancy.
And and it can be for even small dollars. So a lot of people are very happy that their health insurance covers getting new eyeglasses. It's like $300 or $400. It would probably be even less if we didn't have insurance. Yeah. The competition would drive it below that. But it's not something that's going to break you financially. But people will get insurance for it. So it's the opposite. And so it's what that tells me is that it wasn't designed as insurance. It wasn't designed to protect people from financial catastrophe. What it was designed to do was insulate people from seeing the price of health care, and that's its purpose.
And I just want to emphasize the fundamental connection between usage and price. It's kind of obvious, but we don't think about it with healthcare. The reason you don't want to insure against everyday common events is because that's really expensive. Nobody offers a government-run auto insurance policy that would let you get oil changes whenever you needed them. Would be very expensive. Now, no one would buy that in the marketplace. You might buy a little of it. Sometimes there's warranties that implicitly do that. But basically, you realize that if you're the average person and there's some people who are fanatic about changing their oil, your cost of that insurance is going to be incredibly high. If you think it's okay to change it every 5,000 miles, people who are really careful about their cars and want to change it every 1,000 miles, you're going to be subsidizing their usage, which makes no sense whatsoever. So we're doing that implicitly with healthcare, and it persists partly, I think, because people don't realize that they're paying in the form of higher prices. Yeah,
or just take the case of eyeglasses. I don't have any, vision coverage in my health insurance, and so these glasses, I probably haven't gotten new glasses in 4 years. My friend who has vision coverage, well, she and her family, they get new eyeglasses every year because it's $10. I mean, why not?
Which is pleasant.
Yeah. So,
but that's not the real cost.
If it were $10 to me, I would do the same thing. But that illustrates that yes, the law of demand does apply in healthcare. That if you lower the price to people, people will take more of it. But you're lowering the price artificially in that the consumer who's getting the eyeglasses through the insurance is seeing a $10 charge, but the society is paying more.
The political economy of this area is very interesting. The state legislature often requires insurers in a particular state to give you, without choice, those discounted eyeglasses, and on the surface, that seems to the workers in that state, oh, this is great. I have to get this. It's going to be provided. People, don't always think of the cost because they don't see it explicitly. But one of the reasons that insurance is expensive is that there are a lot of mandated coverage requirements that you can't opt out of in return for a lower premium.
Yeah, the mandates are a big factor in certain states, having a lot of uninsured people because, with enough mandated coverage, as you probably were getting ready to suggest, the mandates are really driven by suppliers.
Yeah.
So it's not that the consumers...
But that's because they're so compassionate, Arnold. Come on.
It's not that the consumers are asking for eyeglass coverage. It's that the opticians and so on are insisting on it. And, that's been pretty devastating, for example, in Massachusetts. One of the things that Romney wanted to do with his health reform was he was going to introduce he was going to mandate that everyone buy health insurance, but he was going to take out some of the mandates of what that health insurance contained to make insurance more affordable. But by the time that went through the sausage factory of the legislative process, not only were all the existing mandates kept, but they added enough mandates so that there were now, I think at least a couple 100,000 of Massachusetts people who had health insurance before the health insurance reform are now being told that their health insurance does not qualify as health insurance because it doesn't include some of the new mandates of coverage.
It is also worth mentioning that the health insurance crisis is not always a health care crisis. I find it interesting alongside your point about what we've done to health insurance to make it less insurance and more really is insulation, as you call it, which I think is a great point. We bemoan the fact that people don't have health insurance because they aren't. It implies they're not getting health care. What they're not getting is insulation. Unfortunately, because so many people are insulated, they're buying so much stuff, they're driving up the price that the people who do not have health care insurance do face very high prices for health care, but they are not the same thing. Health care insurance and health care are not the same thing.
Yep, another point, and this is actually drives some of these healthcare reforms, and I think it's not a good driver, is that there is a small fraction of people who don't buy health insurance, don't qualify for government health insurance, but will show up at the doctor or the emergency room
Sure.
and expect someone else to pay for it anyway. And
they're correct.
But the larger point is that, in general, few people are turned away for actual health care in the United States, even though there are many people who don't have insurance.
That's cheerful. Unfortunately, it's that health care is often provided in a very costly way through that emergency room. Although I think there's some indication that the effect is not as large as people might have thought.
I think the dollar amounts are not that
large.
big. I wouldn't make a huge effort at reform just designed to reduce the amount of uncompensated care that takes place.
Yeah.
I wouldn't make that a central issue in healthcare.
Of course, one of the stranger parts of this whole argument is that the thing that bothers me the most intellectually about it is the top-down engineering focus, the idea that we have to redesign the healthcare system as opposed to letting the healthcare system emerge from the choices of individuals, supply and demand side. But instead, we just have to somehow tinker with it with the right mix of mandates and discounts, subsidies, reforms. And we're not good at that. Both the political system certainly isn't good at it, but even if we had a cadre of experts insulated, which could never happen, from political pressure, it still wouldn't happen. Let's close. We're getting low on time. Let's close with your discussion of evolution of markets, which this leads us to at the end of your book. You have some interesting things to say about markets, and you talk about how markets are often sold as being efficient, but that's not why you like them.
Well, as you were talking about your skepticism about, or your concerns about the top-down, you're sounding like a classic Masonomist, and I want to use my phrase, lose the we. So right away we're saying we, it's our healthcare system, and we have to design it. And I think our classic, Masonomics point of view would be, well, what's this we? If individuals, each individual in some sense has his or own healthcare system. You can think of that world, and people, as consumers saying, well, I would like more information, or I would like to be insulated, and this is what I'll pay to be insulated from healthcare costs. Whatever emerges out of that. And I guess
I want to interrupt and just tell our listeners that Masonomics is a term that Arnold coined recently in an essay we'll put a link up to about some of the peculiar philosophical and methodological flavors here at George Mason's economics department. It's a very nice essay, and proud to be part of that peculiar cadre. But carry on.
So in this discussion of evolution markets, I'm making sort of a classic Masonomic point, which is that, suppose that at no point in time are you going to have a perfect healthcare system, that there's always going to be room for improvement. Well, where are you most likely to get that improvement? In a competitive market system where institutions that don't work can fail, and where institutions that do work will be reinforced and succeed. And my outlook on government is that it's much easier for institutions that fail in a government setting to instead be reinforced. I mean, look at public schools and urban public schools as an example. No matter how much they fail, they
just need more money. That's all.
They're just reinforced. Or these insurance mandates in Massachusetts, which Romney thought if he could just get rid of those, he could make insurance cheap, but he can't get rid of those. So it's much harder if you don't believe that you can institute at any one point in time a perfect system, and you think that you're going to have to kind of grope your way, evolve your way toward a better system, then relying on markets is better, because markets, you have competition, you have failure, which is a really important component of evolution. Things really have to fail and disappear.
And be eliminated, yeah.
And be eliminated. And then you also have better incentives for success in a market system.
And therefore,
I would prefer to have more of the healthcare evolution come from markets and less of your top-down, let's lose the we on our healthcare system, instead of saying let's have John Gruber or David Cutler or whatever design our healthcare system. Let's let the system, see if you could get government out of making the decisions and out of trying to decide what's going to be the perfect system, and let it emerge more from decentralized decisions.
My guest today has been Arnold Kling. He blogs alongside Brian Kaplan at EconLog, part of the Library of Economics and Liberty. We've been talking about his book, A Crisis of Abundance. Arnold, thanks for being here.
Thank you.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.